Okay, shall we go ahead and get started? I believe we have a quorum. We have a couple of board members that are on the, joining us virtually. Patty, very quickly, I didn't get a chance to say this, but thank you for asking Gary to get in contact with me about buses for a shuttle. So thank you. That was top of mind. Now we can go on to the Health Council. So thank you, everyone. And thank you, Jefferson County, for hosting us. What a beautiful building. This is just lovely. I haven't had a chance to be here quite yet, but thank you. This is incredible space and really appreciate you hosting us. Let's go ahead and get started with introductions, and maybe we start in the corner with Kelly. Do you mind if we go that way this time? And we'll, oh, you took a bite. How about, okay, all right, because we, sorry.
No. Hi, Kelly Adams, we are Health Council.
Good morning, Miguel Angel Herrada, Health Council, pronounced he, him.
Patty Adair, Deschutes County Commissioner.
Seth Crawford, Cook County Judge.
Camille Smith, Central Oregon Health Council.
Carmen Madrid, Central Oregon Health Council.
Tammy Bainey, COIC.
Linda Johnson, community member.
Emily Solomon, St. Charles.
Hi, everybody. Kelly Simlake, Jefferson County Commissioner.
Seth's older brother.
His bigger older brother. Much wiser. much wiser.
I'm Heather Diane with CASA, Central Oregon.
Wonderful to see you. Yes, Michaela.
Chris Snow, Program Manager, Health Council.
Wonderful.
Gwen Jones, Program Manager, Health Council.
Mike Baker, Jefferson County Public Health, with a warm welcome to our lovely facility. Thank you for your commissioners, and thanks for Carmen for kind of taking this on the road and bringing it here.
Katie Plum, I'm the Health and Human Services Director in Clark County.
Hi, I'm Lori Hill, CEO, Central Oregon Pediatric Associates.
Nice to see you.
Dustin Zimmerman, Oregon Health Authority.
Nice. Okay, Lynn, I think we have Tricia and Mike Shercliffe, I think, is joining us as well. All right, let's go virtual. So looks like Aaron, do you want to, let's see, oh boy, now we're moving around. Okay, how about Jeff? We'll go to you first.
Hello, Jeff Davis with Pacific Source, CCO Medicaid Medical Director.
Wonderful. Looks like you're off mute, but we can't hear you. Megan, do you want to give it a try?
Can you hear me?
Yes. Okay.
It's funny, I could hear Jeff, so that's interesting, but Megan with Mosaic Medical or Mosaic Community Health.
Wonderful. And Jeff, let's go back to you and see if we can hear you.
Took off the headphones. Jeff Davis, you got me?
Yes.
CCO Medicaid Medical Director for Pacific Source.
Wonderful, thank you. Erin, would you like to go next?
Sure, happy to. Hi, everyone. Erin Fair-Taylor, VP of Medicaid at Pacific Source.
Wonderful. Brad?
Hi, everyone. Brad Porterfield, Consumer Representative and Chair of the Community Advisory Council.
Excellent. Leslie?
Hello, Leslie Neugebauer, Senior Director, Medicaid Governance at Pacific Source.
I love it. Hello. And Mike Shercliffe? Yep. And Tricia, I think, wandered in. Okay, Tricia Wilder, great to see you.
I did. Hello.
Hello. All right, did we capture everyone? Okay, next would be public comment. Do we have any public comment? Or anything to bring before the council that anyone wants to bring up? All right, we have Gary. Ta-da! Gary Allen, great to see you. Perfect timing. Yay! All right, so we have you right here. Of course, grab lunch and great to see you. And then we have a few announcements. If we don't have any public comment, going once, going twice. All right, announcements.
Okay, so I do have an announcement that our regional health assessment community survey and focus groups have wrapped up the end of September, and they're compiling the results. So this is the first time a survey has gone out across the region. We have received over 2,800 or more, I don't know if that's the exact number, of surveys, of individual surveys from our community responding to the health survey. And we did 20 focus groups across, again, the region. And so November 1st through November 9th, we'd like you to save the date. You'll be receiving an email pretty soon where the results will be coming out so that there's going to be community participation in elevating, what are the specific topics that we need to be looking at specific to our regions and collectively. And our ask is also, how would you like to volunteer with us and bring your communities along with us? So those emails will be coming out. You'll probably be receiving a phone call from me or staff asking you to participate, make it a date night, make it a family night. There's going to be food, there's going to be an incentive for community members where they will get a $50 stipend when they register and attend at the event. And we will have some reimbursement for mileage as well. Just, recognizing the needs that communities will need to have to support them in that work. So hopefully you'll be hearing from us soon. I want to thank our staff. Miguel has been leading this. Whitney is no longer with us. And Gwen and Michaela and everyone else has been all hands on deck. So hopefully you will all be there to support us.
Great,
Yeah.
okay.
What is that?
Tammy?
November 1 through November 9th.
Yes, Megan, go right ahead.
So Carmen, at the beginning of this, there was a big competition.
Oh, it's still on.
Yeah.
Okay.
I know,
So I have to say that our team is putting out the survey information, but they're not using the right thing. So I'm not getting full credit for all of the mosaic efforts.
Okay.
Just FYI, in case I don't win. So.
Okay. Just an anomaly.
Just
I
an
do have to
anomaly.
say, yeah,
But we're really supportive of, we've been trying to really get that out there. So thank you for the team for leading this, because it's going to be really good information for all of us, I think.
Yeah, thank you, Megan. I do have to say, we've been picking up over 80 to 100 surveys every other week from Dr. Baker. So
Wow.
it's gonna be tight. Yeah.
Okay. And I heard that St. Charles changed out the code on all of the mosaic. Yes.
To redirect.
Exactly. Redirects back to St. Charles. So, I mean, there's a competitive spirit here, which is alive and well. Wonderful. That's great. Okay. And so the sooner we can get those dates locked into our calendars, please let us know so that we can, be a part the 1st through the 9th of November.
Okay. When was the event you were talking about?
There's gonna be different events in different locations, so whichever one is more suitable for your schedule, just attend them. And then we'll be sending out volunteer links if you can get folks to help us volunteer.
Great. Wonderful.
There's one in Prineville?
Yes.
Awesome. Okay. Any other announcements? Okay, consent agenda. We have the minutes from August and September. Any edits, revisions? If not, would be open to a motion.
I will move to approve.
Thank you. Thank you. Moved and seconded. Any further discussion? All those in favor?
Aye.
Aye.
Anyone opposed? All right, thank you, Brad. I see the thumbs up. All right, next we have a presentation from CASA, and as a past CASA, super excited to have CASA in the room today. So what an incredible organization, and thank you for making time to be with us. The floor is yours. And hi, Dan, welcome. Grab lunch, good to see you.
And this is our section of bringing community investments in reporting, as well as the work that they're doing locally. So she will be presenting some pieces that they're doing out here in Nashville.
Perfect.
So.
Yeah, thanks all for having me. And some of you have heard this presentation before, so I appreciate your patience in hearing the second time. So I'm Heather Dine. I'm the Executive Director of CASA of Central Oregon. CASA stands for Court Appointed Special Advocates, and CASAs are volunteers who advocate for children in foster care. So our organization, CASA of Central Oregon, we serve Crook, Deschutes, and Jefferson counties. So we serve children in foster care. What that looks like is our mission is that we're a nonprofit organization that recruits, trains, and supports volunteers to work with abused and neglected children in the court system. So those are kids in foster care, essentially children who are wards of the state of Oregon. Our volunteers work in collaboration with key agencies, legal counsel, and community resources, with the goal that every child in foster care in Central Oregon can transition to a safe and permanent home. Making sure I'm reading that correctly. I've said it a few times. So we can actually, so what that looks like is, if you're thinking like, if you're not familiar with the court system or the foster care system, you might be thinking, why do children in foster care need a court-appointed special advocate? So I'm going to assume nobody has any experience in child welfare and start from the very beginning. And that is that when a child is determined to be in an imminent threat of harm, so several of you are probably mandatory reporters, you've probably called that child abuse hotline a few times of suspected abuse. And then the ODHS, Department of Human Services, will go out and they'll research the child or the family. When they determine that that child is in an imminent threat of harm, that is an imminent danger, and that's an important distinction. They go in front of a judge and they say to the circuit court judge, we believe that this child is safer in the state of Oregon's custody than their parents' custody. Once that happens, if the judge agrees, that's what's called a shelter hearing. The child is now a ward of the state of Oregon and they're in what we consider foster care. From that point on, the day-to-day decisions about the child are made by an ODHS caseworker. The major decisions for the child about whether or not to return the child back to their parents or to not return the child to their parents, to send them to maybe move to a guardianship or an adoption situation, those decisions are made by a circuit court judge. The judge has never met the child and will likely never meet the child. So the CASA program was started in the 1970s in Seattle. So the story goes that there was a judge by the name of Judge David Sukup, and he was making a determination like that for a family. He was making a determination to TPR, terminate a parent's rights. And he's looking around the courtroom and he sees the parents and he sees the parents' attorney and he sees the state of Washington and he sees their attorney. And he realizes that he is making a decision that's going to affect this child forever. He's going to forever permanently legally separate this child from their parents, creating a legal orphan. And he has no idea how this decision affects this child. He doesn't know if the child wants it. He doesn't know if it's in the child's best interest. And so that's how the CASA program was started up in Seattle, is so that when judges are making those determinations about children who they're never going to meet, they always have a community, an independent community member who is there speaking for the child's best interests. So that's what we as an organization do, is we train volunteers to work within the legal system and advocate for children in foster care. What that looks like is our volunteers have access to everything in that child's life, including medical records, including school records, including access to therapy. And so they absolutely can advocate for that child in the courtroom, but they also serve as an advocate for that child in all parts of that child's life. Here in Central Oregon, like I said, we serve Crook, Deschutes, and Jefferson counties. They used to be 3 independent programs. 2005, they all merged into one program. We're one of 20 programs here in the state of Oregon. We are mandated by state statute to serve 100% of children in foster care. All children. The state of Oregon believes that all children in foster care should have a CASA volunteer. What that looks like here locally is that last year that was 439 children. They spent time in foster care. That's anytime from 1 day to the entire year. We served 365 of those children, about 83%, with 170 community volunteers. I am really proud of that. I'm proud that we have 170 folks in the community who are like, yep, sign me up. Like, Tammy, I want to become a CASA volunteer.
And then the time commitment, do you mind saying a little bit about what it means to be, it's big.
It's big. So what that is first of all of our volunteers complete a background check, and then they go through 40 hours of training, classroom training. And we've had our Jefferson County training here in this room. So and then once they're sworn in as a court, then we ask everyone to make a 2-year time commitment, because we know that that's the average amount of time that a child spends in foster care. We tell our volunteers it's about 10 to 15 hours per month of volunteer time. And we also tell them that that varies widely. So sometimes it's a little less than that, sometimes it's a lot more than that. But so when we ask our volunteers, all right, show up in the classroom for 40 hours and then take a case and then do it for 2 years and work within the child welfare system and work within the court system, work within 2 extremely frustrating, slow bureaucratic systems, and work with children who have experienced profound trauma. We have 170 people who said, yep, sign me up. I mean, that's incredible, because this is absolutely impactful volunteer work, but it is not easy volunteer work. And I'm proud of that 83% serve number, because the state average for all CASA programs serving children is about 50%. So here in Central Oregon, we are well above the state average. But we are not serving 100% of children. And I think that all kids deserve an advocate. And so I am actively always looking for additional volunteers. And that is going to be one of my asks of you folks, is how can we get more volunteers? Who can we talk to about becoming CASAs? We know that the time commitment is extreme. It's challenging volunteer work, but it absolutely can be done and kids need it. And I know that we're right here in Jefferson County, so I wanted to point out a little bit here in Jefferson County. So of those children, last year about 65 were from here in Jefferson County. So it's not as, a huge percentage, but it is a significant percentage for the population. So we do have about 9 CASA volunteers who have served kids, and we currently have 9 children who are without a volunteer, and we are specifically looking for 5 volunteers here in Jefferson County. Just to talk a little bit about what some of the issues that bring children into foster care. What that looks like is children primarily, it's abuse, physical abuse, sexual abuse, and then also neglect. And typically it's parents who have some pretty significant behavioral health concerns or substance use disorders. And so they are to the point where they truly cannot parent, cannot keep their children safe. The majority of children do leave foster care and they go back to their parents. So that is the good news, is that the majority of parents are able to stabilize themselves and go back and be able to raise their children, which is wonderful. Yeah.
Does CASA work with the tribes, or do the tribes have their own system?
The child welfare, the tribe has their own system. We do work with children who have tribal affiliation, but it's if they are removed here in one of the Kirk, Deschutes, or Jefferson counties. Those are what are considered ICWA cases, Indian Child Welfare Act cases, and so then the tribe is a party to the case as well, and the CASA works with the tribe. So what this looks like in Central Oregon is I often say that being in foster care for a child is like being between a rock and a hard place. So they're no longer in the unsafe home that they're in. They're no longer in that imminent threat of harm, so they're no longer in the rock. But the foster care is a real hard place for a child to grow up. We do a lot of things pretty well here in Oregon. We don't raise children especially well. And so what that looks like here in Central Oregon is that a child in foster care will have an average of 4 different caseworkers during their time in care. They will live in an average of 3 different foster homes, or what we're calling more recently resource homes, and they'll be in care for an average of 2 years. We want to make it our job that we can't fix the hard place, or we can't fix the rock. We can only influence the hard place, but we can make sure that the child's not there alone. So we want to make sure that we have one consistent CASA during their time in care. So that's why we ask for a 2-year commitment from our CASAs. Some cases are a lot shorter. About a year ago, we had a case that just closed that had been open for 10 years, and the CASA had been on it the whole time. So the commitment of our volunteers is pretty incredible. So when we talk about the one consistent adult in the child's life, it's usually the CASA during their time in foster care. So I specifically want to talk about the Traces program. We were a recipient of a Traces grant, and it made a really substantial impact for our organization. One of the things that it did, we received a specific grant for the Family Find program. So we have what we call a Family Find coordinator position, and that is a position that is a CASA employee that is co-housed within the ODHS Child Welfare. So she has a desk there. And she works very, very closely with the caseworkers. Specifically, she'll get specific cases assigned to her, and she'll build a family tree, and then she will contact extended family. And the goal of that is to connect children with extended family, because we know that coming to foster care, children can lose touch with their family. They can lose touch with aunts, uncles, great aunts, and they can lose touch with their culture, and they really sort of can become orphaned from their family. It gives children a sense of connection and place. One of the things she does, she builds the family tree. She reaches out to family members, building photo albums, which on one hand seems silly, and then you think about what you would grab in a fire as you would grab your photo album. So we're able to give that to children. And then in some cases, it's a case where she's able to find placement for children. And one example, and this is a pretty incredible story, it's not indicative of all of ours, but it makes me feel good, so I'm going to share it, is that we had a Family Find coordinator who was reaching out to family members. They do a lot of, I think what we affectionately call Facebook stalking, and she found a family member. And they said, you know what, it's a cousin, it's a second cousin. And he said, you know what, I am not in a place where I can be a placement for this child. They were specifically looking for a placement for a little guy named Chris. He said, but you know what, we've got an extended family Facebook group. Let me just put in there, see if anybody is interested in meeting him, if anyone wants to be connected. He put in there, we found, I think, a third cousin once removed in the Portland area, and they had considered fostering children. And so I'm happy to say that that child is now in a guardianship with that family, and he's in a permanent placement because of that. Again, that's not all of the cases in Family Find, but of our Family Find cases, which there are about 73 children who we have connected to their extended family, and those are things that it goes above and beyond what ODHS is able to do. So we're pretty proud of that. And that is absolutely because of traces. That position started as a fee-for-service contract with ODHS. It ended because of the traces funding. We've been able to continue it, and that program is still in place. That program has ended in a lot of the districts in Central Oregon or in Oregon in general. It's because those contracts ended, but because of traces, we were able to continue it here. We were also able to increase the percentage of children served with CASA. In 2017, we served 74% of children in foster care, and we served 83% last year. So the fact that we had an increase during that time is absolutely related to the traces funding, and it's in part because we use the traces funding to train more volunteers. So in 2017, we did 3 trainings a year. In the last several years, we've been doing 5 trainings a year. So more trainings, particularly we can move them to different locations like here in Jefferson County, Crook County. We're able to just bring more volunteers in and train more volunteers. What that looks like is during COVID, our advocacy continued. You know, obviously none of us saw the pandemic coming. We were able to move our trainings online as opposed to previously they'd always been in person over Zoom. Court appearances continued over WebEx. We continued training our volunteers so that they could use WebEx, continue appearing in court, continued visiting children. And while we did see COVID had some effect on our work, is that our volunteers took fewer cases, but we were able to increase our service for children during foster care and serve more children during the pandemic when I think they needed caring adults in their lives more than ever. So I just want to say, if you're ever thinking like, what did traces do for us? And we absolutely were able to continue serving children at a high level and serve more children because of it. So I just wanted to say thank you for that. So CASAs are important. And so we can talk about the benefit of a child having that consistent adult in their life, that person who advocates for them. National CASA is the organization that sets our training and sets sort of the basic guardrails of what a CASA program does. They've also done national studies about the impact of having a CASA. And they found that when a child has a CASA, they fare better during their time in foster care. What that looks like is they're more likely to be connected to services. That includes medical services, mental health services, occupational therapy, dental services, all of the kind of things that children who have experienced profound trauma need. They do better in school. They're more likely to have IEP and 504 plans, and they're less likely to be expelled. And then when their case closes, they are less likely to come back into foster care. So having a CASA it's impactful for that individual child, and then it just helps the system function better for those children in general. So we are looking for more volunteers. And so our vision is that more children will have, that all children will have a CASA, because our vision is that all children have the inherent right to be safe, to be treated with dignity and respect, and to learn and grow in the safe embrace of the family. So in addition to me saying thank you for supporting our work and giving some impact report on the traces spending, I also want to say that we are looking for more volunteers. And if you know of ways that people we should talk to, ways that we can try to recruit more volunteers, please talk to me. Because like I said, this isn't the volunteer job for everybody, but we do know that there are people who it becomes their passion. We know that it's impactful for children in foster care.
Maybe I missed it, but I'm still unclear what a CASA does, like on a day-to-day basis, week-to-week basis. They're a special advocate, but what sort of things, I mean, if I know somebody that I think might be a good CASA volunteer, what can I tell them that this is what you're going to be doing besides training?
Yeah, good question. So what that looks like is once a month, it's meeting with the child. And so it's visiting with that child either in their foster home, it's visiting with that child at school, it's developing that relationship, visiting with them once a month. It's getting to know everyone in that child's case. It's the foster parents, it's the child's parents, it's the teachers, the doctors, kind of becoming the experts in everything in that child's life. It's a lot of communication. It's reading discovery, which is all of the documentation related to the child. It is attending any times that there's a meeting or a court hearing that is about that child, the CASA shows up and the child makes sure that the children's best interest is spoken for. So it's a little bit of paperwork, it's a little bit of connection with the child, and it's a little bit of just speaking up. And it's a little bit hard to say, okay, how do you become the expert in the child and you just show up and speak to them wherever that needs to happen. And the reason that's impactful is because we know that the caseworker is going to change, we know that the foster parent is going to change, but is that CASA is that consistent voice, what one of our volunteers calls consistent and persistent voice. We know that those child's needs are just, they're spoken for in all of those areas. So for example, we had a child who moved out of the area with a family member. Well, they changed school districts, and then the CASA said, hey, did their IEP follow them? The school district, oh no, we didn't know that this child had an IEP. Okay, the foster parent didn't know the child had an IEP. The CASA knew the child had an IEP because the CASA was the consistent adult that followed the case the whole time.
So in foster care, once they go into foster care, they're supposed to have a physical health, dental health evaluation within a certain. Is that the CASA advocating for it? Because usually it seems like it's the foster.
It's the caseworker and the foster parent who are supposed to do it. It's the CASA who says, hey, has that been done? It's the CASA who said, you know, we were supposed to have that dental appointment, but it was canceled. Did we reschedule that dental appointment? So the CASA is not necessarily responsible for scheduling those things. The CASA, however, is the person for just kind of just tapping on the shoulder. Just, hey, we know this needs to be done. Or if the foster parent says, oh, I don't remember the name of the dentist, the CASA can say, oh, let me just look that up. I can find that for you. So the CASA is a little bit of support. The CASA is a little bit the tap on the shoulder. And the CASA is also just kind of the listening ear that can just be like, oh, hey, yeah, you're right. That's really frustrating. Let's talk about that. So it's an additional level of support for the child. Yeah.
You implied that was several hours, potentially a week.
Per month. It's 10 to 15 hours a month. So yeah.
That doesn't sound like 10 to 15 hours unless you have multiple kids.
It can be, it depends on what's going on in the case. So there's the visiting with the child, and that's the fun part. So that's the, you know, the drive there, the time with the kiddo, writing up notes. If you've got multiple meetings, so that absolutely can take the time. So if there's, you know, we've got CASAs who go to doctor's appointments, who go to dentist appointments with the children. We have CASA who just, you know, hang out at the therapy appointment to check in with the therapist when they get done. If there's a court hearing, that process can take about an hour. And then if there's a trial related to the case, that can take multiple days. So it depends on the case. It depends on the number of children. We have some cases that might have 4 or 5 kids. Those volunteers are doing well more than 10 to 15 hours a month. Yeah. Yeah. Any of you who have kids in the room or have raised kids, you know the amount of time it just takes to just coordinate and shuttle and talk to all the people. And then we're talking with kids with pretty complex needs. And so that amount of coordination time does that.
Megan, do you have a question?
Yes, Heather, thanks so much for the overview. This is such important, critical work. And as you were sharing your presentation, I was curious, have you ever had an entity provide a CASA volunteer? So I'm thinking like from a Mosaic perspective, could we have a role that could serve as a CASA volunteer as an organization? Is that possible?
I don't, so we have never had that, I can say that specifically. And the reason I'm definitely interested in considering that, the piece that I would have to navigate is, so all of our volunteers, they complete 40 hours of training and then they're sworn in as an officer of the court. And they specifically receive a specific court order to have access to that child in the case. And I don't know how that would work if it's multiple individuals. So
maybe we could talk offline, but I'm really intrigued by that idea and would love to follow up with you.
Yeah, I'm intrigued by that as well. I would love that. Yeah.
I just had a real quick question. It's really clear, I call it ROP, the return on people that's happening here. But I have to ask the numbers question. I'm sure National CASA may have this number. What do you see, how our health system is impacted? Because we just found 73 kids, their families, in your Family Find program, for example.
Yeah. So I don't have that specific data is the short answer. I think so when looking at Family Find, there's the number of children who have been placements, and so those are obviously, when they have gone into permanent home, there's a very specific return on that. There have been some studies that show that when a CASA is involved, the case may be shorter. So that obviously saves the state money in that they don't have a child that's in foster care. The health numbers are a little more challenging, I think, because it's hard for me to quantify the cost of the trauma that the children have gone through. So I don't have a way of quantifying that, unfortunately.
You never know what'll come out of this program, because my wife at the time was a CASA worker. Some of you have heard of the ASK program, where it do orthodontics for at-risk kids. A lot of you know about that. Well, that came out of a CASA program with my wife at that time pestering me, I'm a dentist, pestering me about what are we gonna do with the kids in CASA foster care that can't get orthodontics and get their teeth fixed. Many, many years ago, that whole organization came out of a CASA worker who pestered her husband to have a program, which is now a statewide program. So you never know when you get involved, how you're gonna be impacted by involved with those kids. And so, thank you.
And that's wonderful, thank you. And we refer children to the ASK program regularly for orthodontic care. I can think of right now a CASA who's actively advocating for that additional orthodontic care. She's working very closely with ASK, so thank you.
Wow, thank you. Thank you. Yes, that, it's an incredible program, and you might even become a foster parent through the program too.
Yes,
So that's.
that can also happen.
Yes, that's wise, yeah, so, yes, thank you, and yes, go ahead.
When you came and presented to us not long ago, I just was blown away that day. In fact, immediately I found somebody here locally that wanted to do it.
Nice.
In your presentation, I don't see your contact information. I think that's hugely valuable to
Yes.
share with the rest of this
Yes,
group.
I will get that, yes, thank you.
We'll send it out to the rest of
I have some cards that I can give out.
One parting question, how do you care for your CASAs with the exposure to some of the trauma that they are part of?
Yeah, the secondary trauma, thank you for asking. So what that looks like for caring for our CASAs is that we are every 30 CASA volunteers, we have a staff member specifically assigned to work with them very closely. And so we found that support by staff is really important. We also really encourage a lot of the community support. So building opportunities for our CASAs to get together, to create friendships, we call them the CASA Connect groups. We have a book club. And that seems like kind of silly stuff, but it's also that sense of somebody who knows what you're going through. And then confidentiality is obviously key. It's part of our oath, and really maintaining the confidentiality of the children in the cases we're working with. So we do allow our volunteers to talk to each other about the cases a little bit so that they can express their frustration, get the support. How we support is really through community.
Heather, you need to come back to Deschutes County and do your presentation again.
I would be happy to.
Thank you. Wonderful.
Thank you. I will also put a plug, since I'm in Jefferson County, that we are actively looking for a Jefferson County board member. So if anybody knows of anybody up here who is interested in some board service, we do not currently have Jefferson County represented on our board, and it bugs me, and I think that we need to fix that.
Kelly, fix it.
Fix it, Kelly. Done.
Thank you.
Good, look at
You gonna
that.
join?
Wonderful.
You gonna do it, Kelly?
Oh, he's volunteering his wife.
Yes. Thank you, Heather.
Thank you.
Thanks, Heather.
Okay, next we have Dustin, OHA update. I want to say hello to Shelley. I want to say hello to Divya. Want to say hello to Brian. Want to say hello to Paul. Want to say hello to Dan and Gary. So I think now we've got everybody. So glad everyone's with us.
Okay, hi everyone. Thanks for having me. Dustin Zimmerman. I am your innovator agent with the Oregon Health Authority, and I work with all 4 of the Pacific Source regions, so just for some consistency there. So some basic OHA updates. We decided that might be helpful to bring these to you just so you're aware of what's going on with the agency. Also to make sure that you know I'm a resource to you all, so if you have questions or need more information on something about OHA, potentially Pacific Source, or just anything at the state level, please feel free to ask. And this will just be verbal updates this time, but I'm happy to do other presentations styles if that works best for you. And I think you have most of this information in your packet. So that should be helpful, and there's, we're just gonna do highlights. So first, staffing changes with OHA. Our Medicaid Director, Dana Hiddle, has left. So we have an interim person, Vivian Levy, so you might see that name come across your email or in other notifications. As well as our Public Health Director, Rachel Banks, is going back to Multnomah County. But Kara Biddlecom is stepping into that interim role, and you've definitely seen her name around. Kara's been around for a long time, so that shouldn't be a shock to anyone. Also, we have searches continuing for the OHA Director. No decisions have been made. OHA's Dental Director is also open. We also need a director for the Health Policy and Analytics Division, so that's also open. Also, our Chief Medical Officer position, vacated by Dana Harganani, is still open. So we're missing a lot of people, so if you need links to any of the job boards, happy to recruit.
Kelly?
I'll put in a good word. Also, the Oregon Health Policy Board, their Health Equity Committee is now open for recruitment. That's going on until October 23rd. There's a link in there, so if you're interested in that, want to get involved there, just wanted to make sure that you know about that. We have submitted another state plan amendment. Apparently, we like to do that. And this one is around covering non-routine adult vaccines. So that's by age, health condition, occupation. Mostly those are going to be the travel vaccines. So just something to kind of be aware of. We do need approval on that, but it would be retroactive to the beginning of October. Social needs screening and the referral metric. There's a frequently asked questions document out there that you can refer to now. I know we've talked about that a little bit. It's kind of a wonky thing, something new, how to handle that. So there is a link for you so that you can see the latest information. Also, I just encourage you to go to the OHA quality metrics web pages as you kind of begin to look at those. There's program resources, all of the committees and work groups. There's some new dashboards and reports. So, and it's interactive CCO performance metrics. So for historical reports, so just kind of gives you an idea. Something that I think you'll really be interested in, and there's a link included that you can just go to. It's the Share HRS and in lieu of services comparison update. So that really kind of breaks down those three kind of different funding streams. So super helpful to me. So I'm imagining it's going to be helpful to you too. And so lots of information there. So as you begin to make those decisions just about programs and where that's coming from. So hopefully that is very helpful. And renewals are still happening. Redeterminations are still going on. We did make efforts to correct the 19,000 that got the incorrect notices, and they'll have coverage through December now. And we're still reaching out for them, and that could change because many of them just had not responded. We are in phase 2, the second month of phase 2 of redeterminations. So that's really focusing on pregnancy and newborn, child Medicaid if they're aging out, turning 19, that sort of group. The Bridge program, which we are also working on, nothing finalized there. I think we've even changed the name again, so more to come. And then American Indian and Alaska Native members, and that was really based on the tribal decisions of when they wanted to be sequenced, so working on that. But it seems to be going smoothly. I haven't heard of a new error in delivery of messaging, so I think we're looking good this month so far, but maybe Pacific Source knows different. And those are the main updates for you. Certainly if there are any questions on anything, if you want more information on something.
No question, but just some additional color on the dental director hiring. They actually went through, they were already very lengthy recruitment interview process, several panels. I had the opportunity to be a member of one interview panel and found no qualified candidates. So they're going back to restructure the compensation package and the overall, reporting and organizational structure. But it was very disappointing, the whole process, that they're unable to attract qualified candidates without having the foresight to structure it that way in the first place. That's just my commentary. And if they're going to go through the same sort of thing for replacement of the other staff members, I'll tell you that as OHA in 2023 rolled out some expanded dental benefits with orthodontics and for handicapping malocclusion and the APSDT expansion. The absence of a dental director was very telling as far as fumbling that. So that's just my comment.
Yeah, thanks for that. It's definitely been a struggle and difficult to come into government from a practice like that. Yeah, you want to do good in the community, so understood. Also, just people who've come up for renewal by August, it's 833,678. So that's the numbers we have. So working through it.
Haven't seen a lot of reduction in membership yet.
Good. Pacific Source?
Yeah.
I haven't seen those numbers.
Yeah, Carmen, I believe I'm doing a redetermination update next board meeting, but I'd be happy to share that currently in Central Oregon, as of October 2nd, we saw a reduction of about just over 2,000 members. We anticipate this to continue for the next 5 or so months, and Aaron Fair-Taylor, who's on the calls, initial projections are running very consistent with what we had expected, at about 14% right now, reduction. So lots more detail to come on that, but the process is underway in Oregon.
So I have a question. The medical examiner is not under OHA, is that correct? The fact that we don't have medical examiners, it's taking like a year for toxicology reports to get done. That's what, through this, a different department, the state police, crime, whatever?
I don't know.
Yeah.
I mean, quite honestly, I don't have a problem saying I don't know.
Oh, good. No, that's good. Well, it sounded like you would know.
I'm not sure.
The
Oh, it's the
DA?
DA, okay.
It's incredibly, it looks like we really need to revamp a lot of things. How many more years is it gonna take to get the director?
Great question.
I mean, have they
the last one
interviewed,
that we
like-
hired only lasted 3 weeks, so it's.
Sometimes it says shake again, but.
Yeah, I don't know.
Yeah.
It's a great
Oh,
question.
they lasted 3 weeks?
The
So-
last one that like accepted.
So
the
is
position.
Dave still the interim director
Yes,
then?
he is.
Okay,
Yeah.
because I go to the LGAC meetings once a month and he's normally there.
Yeah, he's there.
Yeah. So- But he's not good enough?
I don't think he wants it.
Really?
That's
I
my-
mean, I
that's my
know
guess.
he's a
I don't know.
finance person,
I didn't
but
ask him. Yeah.
but still.
Yeah.
He has the historical knowledge.
Yes, yeah.
Anything why he doesn't want the job.
Yeah, right, exactly.
He
Knows
the
too
numbers.
much.
I'm sure he wants to retire, right?
Well, Dustin, thank you so much,
You're welcome.
and thank you for, please, yes.
You can have her hand up.
Oh, I know we're kind of over time, but my question, thank you, was really to Dustin and Tricia. Is there a way that it could be tracked? What happens to the lives that redetermine? Like what percentage go on a commercial plan, go to the exchange, or become uninsured? I don't know that there's a way to track that data, but it would be really helpful if that were possible.
I think it could be difficult just because we don't have the connection, or at least OHA might not have the connection to the commercial plans if they go into that. Certainly if the marketplace, we might be able to partner with them. But it could be difficult if they go into private insurance to see if that happens without some individual follow-up. But I can certainly ask to see if we're tracking it.
Anything?
Erin, do you want to lead in with the more details we expect to hear on those individual members over the next 5 months?
I'm not sure, Erin, if you.
If I can get myself off mute.
Oh, sorry, no worries. Yep.
Always fine.
So sorry, I couldn't hear. Could you repeat the question?
Sure. I was curious if there's a way to understand as people are redetermined and they come off of Medicaid, that we could know if what percentage is going on to commercial insurance, maybe the exchange, and then what population stays uninsured. And I'm not sure there's a way to actually track it because of some of what Dustin just said.
Yeah. Gosh, there are certified smart people that are studying this on a kind of population basis. And I'd be glad to share some of that. It's on a lag because there's so much kind of shuffling around. But I can also share with you what our Pacific Source experience, because especially for Central Oregon, since we're, fairly large payer, both in the commercial and the only payer in the Medicaid space other than the state, we can maybe show some trending. So yeah, happy to see what we can pull together.
Great. Okay. Let's move on to audit, and I'd like to say welcome to Kristen as well. And it's my understanding that the audit has not had an opportunity to go through the finance committee, which typically would come back as a recommendation to the board. And so there will be another hop here, but today we have with us our auditors to be able to go through our audit with us. And really appreciate you making time to be with us today. And so with that, shall I turn the floor over? Do you have anything
Sure.
that you'd like to?
No, that's great. Megan, I
Okay.
don't know if you wanted to add anything.
Yeah, I think that we did have a preview of the audit at its status at the finance committee. It was not completed. And so we are here today just to give a high level overview to the group. It will go back through the finance committee for a formal vote and recommendation for the next board meeting. But Shelley and Brian, thank you so much for being here. And this is a return and new for Shelley to come back, and it's a big lift, and they've just really dug in and looked at all the different areas, and we appreciate your due diligence and thoroughness with the audit for this cycle. So I will hand it over to the two of you.
Great. Can everybody hear me okay?
Yes.
Great. Brian Newton with Jones Marath, a partner and the lead leader for Central Oregon Health Council. Actually worked with the organization a number of years ago as well, so it's great to be back working with the group again. I'm accompanied by Shelley Ombrambowski, who's a manager in our firm, who's really the reason the work is getting done. So thank you, Shelley, for working with the team. I'm going to take, as Megan mentioned, a pretty high-level overview. We did actually go through in pretty good detail with the Finance Committee meeting already. We just had a couple minor tweaks since then, and we're close to finalizing things for the approval at the next Finance Committee meeting. So we're looking forward to finalizing and wrapping this whole thing up. Always, I like to thank Carmen and the team with COHC because it takes quite a bit of effort on their team as well to work through an audit process, especially when we're back new to the organization, of course, and Carmen's experience being new to the organization herself. So really thank you for all the efforts on all parties. As I run through this, please feel free to interrupt me, just speak up and we can answer any questions as we go along. I'm happy to be interrupted. So again, I'll just do a pretty high level overview, the anticipated results, and highlight just a few things, and then let everyone kind of take a moment and see if there's any questions here at the back end and maybe try to catch you guys up on your agenda a little bit. I'm able to share my screen, I assume, hopefully. Let me try that.
We have a question right out of the gate.
Oh, of course, please.
No, I'm just trying to process. So it's gonna go back to finance and then come back here, but why?
Because typically we have a process that it goes to finance committee once the audit is completed. And then they review, see if there are any recommendations or anything that the board needs to be aware of. They would make that recommendation to the board. Unfortunately, it wasn't able to happen this time, so.
So it's just a timing function.
It's a timing function.
Okay.
Yes.
That's what I thought.
How does the size look on people's screens? I use pretty big things, so I want to make sure.
Question. Why didn't we just wait? Like, is there something we need to do today? The agenda doesn't reflect that. It says info. So why didn't we just wait?
So this came to light just recently.
Okay.
And so we decided to go forward with the information today.
Okay.
And so we will not have them present again next month, but we will
We
have a
will just
recommendation
note
from
that
finance
finance
committee.
approved it.
Yes,
And
yep,
we wouldn't expect changes, or I guess we'll leave that to the process.
yep,
Okay.
yes.
Broadly, that is correct. There's not expected changes from here forward. That is correct.
Yep.
Do people see the financial statement screen, and how's the size looking for readability?
You're sure doing it looks good.
Okay, great. So again, I will do this pretty darn quickly since we went into detail before. First, we'll start with the independent auditor's report. Unless something surprising happens, we anticipate providing an unmodified opinion. So you can see that at the very top of the auditor's report, that we believe the financial statements are fairly presented, consistent with the United States generally accepted accounting principles. So the best opinion you can get in the terms of an audit environment. The rest of our report is pretty just explanatory in nature, so people can read that at their own volition if they'd like to do so. The other thing I will highlight, which is very common in the nonprofit industry for nonprofit presented financial statements, is that the prior year information is considered a comparative summarized version of the financial statements that were audited for the prior year, primarily because the statement of functional expenses gets very big when you do a full presentation. So it just highlights to users that it provides total balances, not necessarily every single detailed balance that you would expect in a full set of financial statements. All right, I'm not going to say really anything about the statement of financial position other than just the organization is in fantastic financial health and incredibly liquid in its financial position, has the, of course, wonderful nature of not having any significant long-term debts or obligations extra than its kind of operational items like grants payable and accounts payable and payroll. So great to be involved with and have an organization that doesn't have a lot of obligations to worry about above and beyond operational activities. On the statement of activities, the main thing I just wanted to highlight here was the presentation setup. Did I hear a question or a comment?
Not yet.
Okay. Is the presentation setup of the financial statements. Again, with a new auditor, we help and assist in preparing the financial statements. So sometimes they have a little bit different of a look or flavor or feel with a new auditing firm that helps prepare these financial statements. This isn't necessarily inconsistent with history, but wanted to highlight again the nature of the organization with all of its pass-through type activities. We feel, and through discussion with Carmen and management and the finance committee, that's valuable to show the gross activity of the organization on the financial statements, even though a fair amount of it is custodial in nature. So just so people can kind of see this quickly, we show all of our revenue streams here on a gross basis, but then we do subtract out from total revenue any custodial type nature payments out. So in other words, it's not included in expenses, but instead included above the line in part of revenue, just to show the ins and the outs. So again, part of the QIM is of course custodial in nature and pass-through in nature, and shared savings is totally custodial in nature. So you'll kind of see those matching positives and negatives here on the top line. One other item to highlight, this 2.449 million with donor restriction column is the amount that's specifically restricted for use in the behavioral health industry. So that's why that's called out separately as the restriction of the specificity of the type of funding that needs to go towards on the downline perspective. On the statement of functional expenses, you will see, of course, a substantial jump year over year of total expenses, 4.5 million up to about 10.5 million. Of course, the vast great majority of that is built into grants paid down to other recipients. So of course, all that increase for the most part comes in these numbers here. So again, understanding and realizing the type of organization this is, it's critical to know and understand that this type of jump in expenses isn't something to be overly concerned about, because it's really not operational expenses from the term of, you know, salaries and benefits, occupancy, all those good things, but it's through a true impact by paying down grants to other organizations. Similar in nature, kind of a new flavor on the financials presented this year. Historically speaking, all of this dollar used to be in one line item called program expenses. Similarly, we felt it was a lot more valuable to show a little bit more detail at the face here. This is truly what that is and where it's going, with a little bit more descriptive nature of exactly where those funds are being used for and being paid down by others through various grant programs. Statement of cash flows. Again, quickly on the statement of cash flows, I will make users aware just so they make sure they can tell quickly. There's also a note disclosure that addresses this, but you'll see the total cash at the end of the year shows nearly $20 million. That includes both cash and the CDs held, the certificates of deposit balances, which historically speaking, those were broken apart on this statement. Very technical GAAP stuff, but because the CDs have original maturities of less than 3 months, they are considered cash equivalents per GAAP standards. So that's technically considered a cash balance because of the short-term maturities of those certificate of deposit holdings. So again, just want to make sure people kind of see that distinction at the face here, because if you were to look, hopefully not to make anyone sick, at the statement of financial position, cash is stated here as 9.6, CDs is 10, because I think, again, there's value to show that differentiation here. But in the statement of cash flows, it uses the terminology of cash and cash equivalents, which is inclusive of both of those items. All right, on the notes here very quickly, I'm going to jump all the way to page 9. Note number 1 primarily just talks about the organization and its accounting policies and things like that. On page 9, I will highlight here is the disclosure regarding FDIC insurance coverage, and it is required to disclose the balances that exceed federally insured deposit limits with financial institutions. That number being 9.5 million for the year is just worth mentioning to the group, which we did have a discussion at the finance committee meeting about, just to be aware of the risk of bank failures, et cetera, for dollars that are on deposit. It's our understanding that that is right now an ongoing discussion and determination of potentially a policy and organizational change to reduce that potential exposure. I do always like to share that history tells us it's really not a substantial risk based on history. Even when bank failures have happened before, dollars on deposit have not historically been lost on folks that bank at such institutions regardless, because it's usually acquired, absorbed by another financial institution, and not truly lost in those circumstances. So again, not something to ignore, but up to interpretation of truly what kind of exposure risk that truly represents. Next page, on page 10, I will mostly highlight this. I'm not going to read through it, but I'll highlight it primarily for the finance committee, because one request from that meeting was that there's a little bit more connectivity appendices, if you will, of the acronyms and language in the statement of activities specifically to what exactly that represents. So we've expanded this revenue disclosure from here to here to more directly correlate with the acronyms on the statement of activities, explaining those different types of programs the organization is running and where you would see that on the revenue streams of the organization. And I will flip all the way to the very end. And it's finally highlight for the group, again, just awareness, because I talked through it. There is a note here towards the end that mentions reclassifications. I just highlighting that so that people are aware that didn't change or restate the prior year financial statements in any way. In other words, change in net assets or net income or performance for the organization was not changed on a reporting perspective, just purely how certain things were presented from the prior year financial statements that were issued, like I discussed previously. So that's just a note to make users of the financial statements aware that some numbers, words, presentation, and the comparative nature will look a little bit different if you were to actually look at the 2021 financial statements next to the 2022 financial statements, but nothing changed from an operational perspective. I know that was pretty quick, but that was my intention. So I'll stop sharing for the moment and now pause to see if there's any questions, comments, concerns, or otherwise.
And Shelley, would you like to offer anything, or how'd he do?
Brian nailed it. And I mean, I have worked with him 5 years, but he also nailed my last name. So I, of course, appreciate that. I just want to echo what Brian said and thank Carmen and her team for the amount of information they gathered during the audit process. So thank you very much.
Now, thank you for working through us, especially my first year doing this for COHC, as well as your first year with us. So, happy to see the results and how they turned out. So thank you.
Any questions from board members?
My only question was around the insurance coverage, so Brian covered that.
Okay.
It's like finance committee has that on the.
Excellent.
So what kind of interest rate are you guys getting on, like, your certificates, the 10 million?
The 10 million?
Yeah.
It's market rate. I don't know the exact amount. I know what we are doing right now for that exposure, that $9 million, is making sure that that will be swept into an FDIC insured account. So that was a discovery that they weren't. And most of those are pass-throughs anyway. We get the check, we write them out the door. But when they do sit there, that's where the exposure is potentially there. The rest of any other balances go into a CD account, a CEDARS account, until we need them. So there is a discussion that at some point I'd like to bring up is, do we put these dollars into a money market investment? Right now, money markets are returning between 4.5% to 5%, but I don't know necessarily what the CCO guidelines are around that, because we're earning interest off of, community dollars, but those dollars could go out to the community as well. So another topic of discussion, I think, and maybe in finance.
So to that point, first, is there an investment committee of any type, or
We don't have an investment committee, but we have a finance committee, so that's a great question. Yep.
secondarily, would COIC be allowed to join LGIP? Would you be able to take, because
I
that's,
don't know.
that's at 4.5,
Yeah.
4.75 now,
Right.
Yeah,
and it'd be something to look at, but.
yeah, there could be something there. We are technically a 501c3, but there's there could be other ways that we look at that though. So let's look into it.
At least.
Isn't it
some
like
of
a $50 million limit or something? So you could definitely fit a
Yeah.
limit. Yeah.
So will those recommendations, will those topics come back from finance for us? Oh, and Brad has a question too, but so this will go to finance. We'll talk about both the insurance piece, we'll talk about, and let's raise the question about
Insurance investments.
about an investment committee too. And maybe it's a quarterly, maybe it's, who knows, but
Okay.
that'd be great.
And if it's within the guidelines of our contract.
Yeah, wonderful. Brad?
Hi, yeah, I just wanted a clarification on that. I noticed there's a $598,000 grant to Creech Consulting. What is that for?
Gosh, I don't have the
Creech
project.
Consulting?
So
It's, go ahead.
that grant was to decide, to find a way to measure. Let me find the information.
Okay.
But it's a program that is still ongoing.
Okay.
And we don't have the financials yet.
I'm the advisory for that, and so it's trying to link primary care and behavioral health in a closed loop referral process. And that turns out to be a lot more challenging than you would think. So, so that's the project. And it's funded through the behavioral health work group.
Is that a multi-year project? That's a lot of money.
It is.
It's over $1 million.
It is a multi-year project. I mean, we're happy to report on that and bring Creech in as a follow-up.
Maybe as a follow-up also, Brad, we could just provide that information in a follow-up email with a little bit more detail.
Yeah, thank you.
You bet. Sure. Other questions? Yes, sorry, my back eye's shut, so I threw something at me.
This is Trish Wilder. I'm asking on behalf of my role in the finance committee. I'm curious how some grants are named here, but not all, and what that designation was to be included in this space. As I look at Creech, that's a RIP work group grant, as I understand. And then down below, there are some quality incentive measure grants, and I know there's many CAC SDOH grants. So I'm just seeking to understand which grants were identified to be included in this space, and perhaps which ones were not necessarily included, and then maybe just why.
Are you specifically speaking to the note number 2, grants payable?
Right. Yes.
So broadly, it's because that is what was still to be paid out as of the end of the reporting period, 12/31/2022. So this would not include every single grant issued during the calendar year because they might have already been paid.
Right. Basically grants that are still to be paid and on our books to be paid. Does that help?
I think there's still a question. So that's missing a block of grants.
No, basically what it means is it's whatever grants that are still on our books that have not been paid out yet. And that's why Creech is there, because it's a multi-year grant, but we have to account for it that it's actually still to be paid. Just like a liability or anything like that, but we call it grants payable.
Okay.
So in other words, maybe if to help connect the dots, if you were to look at page 3, which is the statement of financial position, you see a grants payable balance of $3,323,872. That disclosure is sharing the details of that balance that is still to be paid, so as a liability. However, the total grants expensed or issued, not necessarily all paid, is going to be those four numbers I had highlighted on page 5, which is about $9 million. So in other words, it won't include, that specific disclosure won't include a listing of all the grants actually issued and paid during that same period, only the ones that are yet to be paid out in cash.
So are we missing about 6 million in grants?
It's not missing it because the disclosure purposely.
Well, I'm trying to
Words you never wanna use. Differently, perhaps,
Okay.
versus missing, which is
Yeah, no, I'm not.
potential,
Yeah.
potential challenge. Are all the grants under 2.0 in the continued space, were all of those quality incentive or quality pool payout grants?
What page are you at?
I'm on page, and again, I think there will be an opportunity, and we may need Brian and Shelley to join us. I'm curious, Megan, who's the chair, to join us as we debrief this information more. It's on page 39 of the packet. At the top of the page, the grants payable continued. I'm curious, that specific list of grants that were unpaid as of December 31st, 2022, correct?
And Tricia, what I'm gathering is there a way to account for more specifically the dollars that came in, the dollars that went out during the year, and the dollars yet to go out more specifically than what we have currently, so that they can be tracked better? Would that be helpful?
From my perspective as a finance committee person, in order to make a recommendation or better understand this, that would be helpful for me, Megan. And I believe it's what is the heart of what I'm asking, is to trace these back to their investment sources and or buckets.
And we can, because I know that our books right now have cleared our grants payable. That was the intention. So.
And so Brian and Shelley, is that possible to make it be more specific for the ones that have been already paid?
So it would probably take adding a disclosure. So again, the note number 2 that we're referring to is not going to include all grants because it's specifically listing the grants that are still needing to be paid. So in other words, from a financial statement world, the perspective is a more critical piece of information is understanding what a liability owed is at a given point in time, right? So owing $3.3 million is a substantial liability. So there's value in understanding what does that liability yet to be paid at that time represent. There's not as much required disclosure around the expenses of all issued grants, but it doesn't mean you couldn't add a disclosure that lists out all of the grants that match the expense number instead, or as well as the payable number.
I think that'd be helpful just because it's such a unique model with the way the funds come in, and it's hard, it's like a pachinko machine. It's hard to like track everything. So I think if that were something that you guys could do, that would, I think, be helpful for the whole picture. And I understand like it's a point in time, but I just think it is a unique way that money comes in and money goes out.
Yeah.
And if I could add, a majority of this, because we did get our dollars later in the year, was a lot of this were the QIMS payable dollars. So if you look at ODS, St. Charles, Summit, La Pine, that's part of the distribution of QIMS and shared savings. And so all of these cleared by the end of the year. So just FYI.
But I think it would give us a better perspective and the transparency if someone is looking at our audit and looking at this as a complete picture. That notation might give it a bit more clarity and call it out.
Yes.
Yeah. So just as a FYI, as the auditors, Carmen will just need you to provide us that full detail, because as the auditors, we haven't looked at every single payment that's been paid. We look at, a subset and sample testing. So we'll need you to provide us essentially a schedule of the total number on page 5 of the grants by recipient to add that to the financial statements.
Okay.
And we can talk more about that offline, Carmen, but.
Okay, great. Thank you, Brian.
Great discussion. Okay, anything else? All right. Thank you, Brian. Thank you, Shelley. Thank you, Megan. Next on the agenda, we have Kristen, and we're going to talk about the CCO health-related services investment guidelines.
Hi, Kristen. So Kristen and I decided to tag team this presentation together, really because it's a partnership with Pacific Source in making sure that we're in alignment with our health-related services investment guidelines. So just to kind of set some context on this, and a lot of this information is also in your binder, the board book binder that was sent to you at the board retreat or that you received. So just to kind of set some context, back in 2021, in December, a CBI delegation was signed by our council, basically saying that our investments or any community benefit initiatives, need to be aligned with our HRS guidelines that the CCO and, designated through OHA is in alignment so that all of our investments need to stay within, really these parameters. And so prior to that, and the reason why that was really called out was a lot of our investments were reported through a vehicle called Exhibit L. And Exhibit L basically says if whatever investments that you're putting out into the community, we take a look at that and we measure it and say, okay, what are those dollars that are going out that are eligible? Well, when our I'm going to just show you a graph here really quickly. I know many of you can't see it very far, but it's basically a graph that says this is how we ranked against all the other CCOs. Ours came in the lowest because we weren't reporting enough of our investments that were aligned with this. And so what we decided to do was take a look at this. And so our HRS guidelines now, all of our investments, so that we can report it to the state that we're in line with these guardrails, is that as long as we're investing here, we could actually report more dollars. So in a nutshell, if we were investing 5 million, maybe only 1 million was being reported out because we were outside of those guidelines. Now we are, and we're working really hard with making sure that our grantees understand this because there are some sort of limitations in terms of our investments. And I'm going to pass it on to Kristen. I don't know, Tricia, if you want to add anything else to that, or but Kristen has really been the expert in this space, working along with Kelly and our team to make sure that when grants are going out there, they are meeting these guidelines. That said, there is some room we're hoping for, maybe advocating to say, well, there are some areas we're hoping we could actually make a difference. But I'll let you take that on, Kristen.
Thank you, Carmen, and thank you for having me here today. I'm sorry I can't be there in person. My name's Kristen Tobias. I use she, her pronouns, and I'm the Senior Community Health Coordinator for the CCO here in Central Oregon. I started in 2020, just as 2.0 was sort of launching. And also, I think some of the first time we really got feedback about investments that the CCO and Health Council were making. And Leslie was my supervisor at the time and said, can you learn all the rules and the guidelines around health-related services? And I said, sure. And so, yeah, I became the de facto expert, I guess, within Pacific Source. And it's been a real pleasure to work with Carmen and her team as these guidelines. Yeah, I'm the expert now, I guess. But it's been really nice to work alongside the Health Council to just, understand the rules together and make these investments for our community. I think what makes us unique, as you all know, is we're the only CCOs that have a joint management agreement. Actually, we can move to the next slide. And so we sit at the table with our community partners from various organizations to determine the best investments and what our community needs to be healthier. And through the delegation agreement and joint management agreement, the Health Council manages our regional health improvement work groups, regional health improvement plan work groups, and the Community Advisory Council, where many of these investments are made. So just as a reminder, our joint management agreement. Next slide. So health-related services fall into sort of two buckets, sort of individual member and community level. So flexible services, individual member level, when we report that on our annual financial exhibit L, we report flexible service investments by member ID, the item that they received or service, and the OHA audits that. And then for any community-wide investments, those are community benefit initiatives, and those are at a more community level. They center our CCO and OHP members, but the whole community can benefit. That's the hope. Next slide. Oh, and just sort of as an aside, flexible services and community benefit initiative investments would be for non-covered services. So the CCO, part of the covered benefits would be physical health, dental, non-emergency medical transportation, mental health, things along those lines. So, oops, sorry, can you go back? So flexible services, again, some examples here. So weighted blanket, gym memberships, emergency housing assistance, utility assistance, and other types of non-covered durable medical equipment and services. And those are all submitted through our Flex Fund team through an application, typically through a provider's office and sometimes through community-based organizations as well. Next slide. So community benefit initiatives are projects, again, focused on population health and healthcare quality. They need to include, but are not limited to the OHP and CCO members. So some examples of projects that have been funded are active transportation infrastructure, safe routes to school, improved bicycle lanes, and public transit improvements. Preschool and kindergarten readiness programs. That's going to be a big initiative next year and for I think the next 4 or 5 years after that. Community diabetes education programs that provide culturally and linguistically appropriate resources. So again, this would be something available to like at a community level versus a one-on-one level. Food pantries and other types of programs that provide healthy food to communities, to rural communities, projects that improve community parks and playgrounds to promote physical activity and inclusivity, shower and laundry trucks to serve our unhoused community members. And another example would be free menstrual and hygiene products available in schools or public places. Next slide. And then to qualify for health-related services, it must meet at least one of the criteria listed on the screen. For the investments through the Health Council, a lot of them fall under number 5, implement, promote, and increase wellness and health activities. Or number 1 sometimes too, be designed to improve health quality. But a lot of the items listed here might be focused on flex funds too. Next slide. And as just a reminder, these are the regional health improvement plan priority areas through the end of 2024. So the investment should also align with one of these 6 measures or priorities, I'm sorry. Next slide. And the not so fun part, but the exclusions, and I can let people read through this themselves, but I think something worth noting is just that as the new waiver, the 1115 Medicaid waiver rollout, and as we receive more information about that, these exclusions might change slightly. We'll see. And so I think part of this work that is challenging but also exciting is that it is really fluid. And as OHP covers more services, people can bill for those services. And so they might not be able to be covered at a community benefit initiative level. I'll take a breath and ask if there's any questions now.
Yes.
Kristen, I have a specific question just because I'm pondering this myself right now. I've been meeting with the Crook County Sheriff, trying to figure out how to get medication-assisted treatment into the Crook County Jail. He tells me that over half his inmates are withdrawing from fentanyl. And then when they're released, they're at 27%, 27 times the risk of overdose than when they came in. And so I think I can use some Measure 110 funds to get that thing started, but sustainability is an issue. And and they lose their OHP coverage going in, and then virtually all of them go back on OHP within a month or two of leaving. Is there any avenue for this?
I think what makes that slightly challenging is what you pointed out, in that most incarcerated individuals lose their organ health plan while they are in custody. I believe, though, that legislation passed recently. Hopefully, Aaron is on the call and can correct me if I'm wrong, or someone else, where people who are being released from jail or prison would be able to renew or enroll in OHP before they leave jail, to help make sure that if they need an appointment to access behavioral health, physical health, dental, all of those things, that when they leave custody, that those appointments in theory could even be set up for them in advance. I used to be an enrollment assister at Bethlehem Inn, and it was really, really challenging. We would have people that, would just sort of churn in and out of jail, and it could take 30 days for them to be assigned to the CCO again. And maybe they've already been out of jail for 2 weeks. And so I saw Erin turned her camera on, so I'm hoping she can speak more about people being back on OHP before they leave jail.
Yeah, we're probably a year or two away from that being a reality. It is a part of the 1115 waiver that was approved last year, but CMS put a pause on that part of the waiver because 10 other states also asked for the authority to do that, and they wanted to have the same criteria at the federal level to apply to all of those states. California was the first to get awarded that authority, so we're going to learn from their experience. And literally this morning, I got a request from OHA to provide some contacts at Pacific Source to begin the work of planning for exactly what Kristen described. So it's not in effect yet, but it is coming.
So I'll just make a case. Pacific Source is the best CCO to deal with in the state on these issues. So I'm saying this in full acknowledgement that you guys are great, but this is a rapidly changing environment, and what was a true story 2 years ago is completely antiquated information. I've never seen anything like this since the AIDS epidemic in the early 80s. We're just losing a generation of people, and they're just dying. And you talk to the jail commanders, and very, very difficult management because of the high rates of opiate addiction, and they're just coming in way more addicted than they were under heroin, and huge management issues. And you know, Crook County Jail criminal justice system is not a hotbed of liberal, sweet, and taking care of inmates, you know. And when they come to me and say, we need help, and we're all in agreement and alignment, it's a big deal. And it just tells you what's going on out there on the streets. We've lost more people in the last year than we've lost in the 25 years before, put together. So it's a big deal. And I don't think we as a system has really responded.
So let's ask this, maybe this is naive, but if Carmen showed us this graph and it looks like we were not capturing quite
all of our investments.
right relating to the HRS requirements, correct?
Yeah, and I don't know
What if-
whether this is the right vehicle.
Yeah,
right.
I'm just throwing that out to Aaron and advocate and, you know,
Because while we have a captive audience of individuals that are incarcerated, it's a great place to actually help get them stabilized if you can. And my question is, if we were that low before, what happens if we did spend a little bit of this on something like that and it doesn't qualify for the HRS? I mean, clearly we were way out of line previously. What if we went up like 6 notches? And maybe that's a naive question, but what does that look like?
Sure.
Yeah.
I would like to share that, and this is hot off the press, on its way to Carmen, this news, but we're closing the 2022 books with $11.6 million in shared savings.
Okay.
That means that 50% of that will go towards behavioral health investments. My suggestion would be, as the work groups are being formed, and I believe, Rick, you're part of that, is to look at a way once people have transitioned back onto OHP, what processes can be put in place, what services can we provide as a community to wrap around people who are coming out, getting reestablished with OHP in the interim until we have more HRSN specific housing available, but we also have a tremendous amount of housing work happening, coinciding in our community. So I think these two investments could align to help make a difference in this space, Rick. I would point towards that.
just a practical thing is, if you don't shoot them with Sublocade before they leave, they will walk out of jail and turn straight up to the dealer. I mean, it's nonstop. They just go, and it's those first 72 hours where the deaths are happening. They don't even, like, the PO's office is 20 yards over there. They're supposed to go there. They turn right instead, and that's.
Well, let's not let go of it. It sounds like there's some funding opportunities.
Right.
But what I'm hearing is still the gap while they're incarcerated, because that falls on the counties.
Yeah, you gotta get
And
them
so,
while they're there.
right.
Ideal Options, I actually went there on, I think it was Tuesday, had a meeting with them. And they actually, I believe Chandra is going to like the Deschutes County Jail. And she is a peer person that's in there and, trying to get them part of the program. Now, they actually went into Redmond and into Bend. They said their Redmond numbers had really fallen off with people coming in for those injections. If they can get 7 injections into someone, that in some cases can last for 39 months. Now, I'm sure for me, it would only probably last for 3 days. But if you can, start getting those injections, it makes such a huge, huge difference. And they really feel like that's the direction. So that was with Josh Lair, and who is the director. They're in 11 states now, but really nice to see what they're doing. And they actually said law enforcement, if they have somebody that's on the line, they can actually drop them off at one of their places.
Okay.
Right.
And I think that's
They're
really.
partners with us, and we've sort of set up similar systems, basically walking capacity. Because what we've found is, we don't have that, people are dead.
Right, it's so bad, I know.
So it sounds like there's more to unpack here. And let's see what we can spend, because I'm hearing both. It's when they're in and when they're out and before that
You've got to
space
get them
too. Yeah.
engaged. You know, they get one shot and then 2 weeks later they get the second shot and then it's once a month. But it really does make that difference. Otherwise, we're losing people. Gosh, didn't we hear that we just had to somebody had to have a case of Narcan to not die? Because, and then I believe Representative Levy said the other day that it's going into people's fat cells, the fentanyl, and it's sticking in fat receptors. So everyone get rid of your fat receptors.
So do you want to take that? Do you mind reporting back at another time where we can find out a little bit more about how we might do that?
I'll be pestering them.
Okay, very good. Okay, sorry. Okay, Brad, did you have a question?
Oh, the injection is Sublocade. It's a long-acting version of Suboxone.
Thanks, Rick. And I'm just, the question is there any type of an emergency process, you know, that would allow for a waiver to be able to supply funds to that, address that issue, as opposed to waiting for this bureaucratic process to go across 10 states, whatever that was that somebody shared, that the OHA gal shared. Is there any way around that?
I think that right now the ability to enroll in an incarcerated individual, whether that be in prison or in jail, it's up to the CMS. So that's at a federal level right now, Brad. And I don't really know why it is that people aren't able to have their OHP turned on again before they leave jail. But I think that it's just because it's being held at a federal level. I know that there is federal legislation in 2019 to also be able to have people enrolled into their state Medicaid plans before being discharged from prison or jail. And it didn't pass, obviously, but I don't know, maybe there's hope that it could pass, like at a nationwide level. But I'm also happy, Tanya, who is our community partner outreach program OHP application assister, I see her next week, so I can talk more with her about that. I know she's worked really closely with our local jails to see if there's a way to have an OHP assister on site or close by. But again, even if somebody qualifies like in that moment while the application is being completed, it could still take 30 days for that person to be enrolled into the Pacific Source CCO. So in that 30-day period, they would still have open cards, so fee for service OHP, but I'm not sure if that makes access to care more challenging. I just am not sure.
Rick? So let me see if I understand this correctly. This is a bureaucratic regulatory issue that gets in the way of money we have sitting there to help somebody so they don't die. I mean, is it just because the rules don't allow it to, seems like the money's sitting there? So it means the rules don't allow the money to be spent on people, so we let them die? I mean, I'm just trying to be as blunt as I can.
Well, I mean, that's the result. I mean, I get the reasons why.
If we get at the reason why, then it seems like
but I'm questioning the validity of those reasons given, you know, what we're seeing on the street these days. And again, Pacific Source is easily the best CCO. It all goes south from Pacific Source. So some of them are, you know, really stuck in rules that sort of made sense 5 years ago, but don't make sense anymore.
And one may ask, why are people being dropped off
That was my question.
when they're incarcerated so that the counties pick up the care and then we have to put them back, re-enroll? This has been a NACO issue forever. But it's some people who need higher level of care and can't afford certain things. There have been cases made where people go in incarceration to be able to get the care that they
Right,
need. And so,
the sort of graphic problem is, if you're withdrawing cold turkey from high levels, these are worse than heroin, well, you're vomiting and diarrhea all over the place. And that's a real when half your inmates come in looking like that, it's a big problem for the jails.
Yeah.
For me, listening to this, it feels like two different issues. One is a community issue, whether you're OHP or not. People are coming in, we don't have community capacity yet, and we have a pot of money, some of which maybe hopefully can be used to build the capacity. And then the OHP and the insurance link is the entitlement to that. And so it feels like we have used funds for both capacity building, and as the entitlements increase, we have more funding for OHP members to access that capacity. If we don't have capacity, nobody gets it. So it's a bigger community problem than just OHP, and anything that we can do, think creatively to build capacity in addition to the entitlements, I think benefits not just OHP members, but also the whole community.
Are there any conversations about not taking those inmates off?
I'm not taking them off of what?
OHP or?
Didn't she say that's gonna take a while, a couple of years?
Well, I think it's more like, I thought she was talking about it takes longer to put them back on. And that's what we were.
Well, you can get them back on the DMAP open card. And then it takes another month to get on the CCO, but that's not a problem. I mean, for our purposes, we can use the open card just as well and be able to fund things. It's the question that when we talk to the clinicians, the ideal is to get them started a couple months before they leave. And what you're trying to do is if the sublocade is on board, they're far less likely to overdose. Even if they use, nothing much happens generally. And so, and then you've created some motivation to hook them into treatment ultimately. Which is what you want to do in the long run, so they don't go back to jail. So that's, so I have some underutilized Measure 110 funds in the county, so I can get something started without all this. I'm just looking for sustainability funding.
Rick, is it an oversimplification to say you've articulated the problem, or at least a component of the problem, and it's clearly the opportunity is avoid death, avoid unnecessary death, and then said, okay, what is the intervention that could actually help do that? People, process, medications, etc. And then we could say, here are the current limitations in the system of getting some of that paid for through what might otherwise be available sources of funds. But then come back and say, how much of that can we solve for by doing it in a non-HRS capacity or doing it in a different way? Because we can easily get wrapped up in the cans and can'ts of eligibility and this law change that may come in a year or 2 years. But it feels like what you're saying is let's understand the true gap we have to avoid unnecessary death. Make sure we have a clear understanding of programmatically what can we actually do, and then map that to available funding, and then map that to rules and rules.
Yeah. I think we're budgeting out, and we can work with Ideal Options in Deschutes County, and I'll be talking to the jail commander in Jefferson to see where they're at. I mean, each county looks a little different, but And we can map out, and we're budgeting right now what that would cost per inmate. And so then I'm just being really creative about where we find the funding. So.
Yeah.
I'm sorry to take some time, but.
No,
Well, thank you for raising it, yeah.
When we were in the Pine, I know you told me that you lost 7 patients in 3 months, and it now sounds like it's only gotten worse.
Oh, yeah. Yeah, we lost 3 patients in 1 week, 2 weeks ago.
Okay.
Coming out of incarceration.
No, these are just in general.
You actually said that those were patients, and normally you'd only lost 1 patient a year prior.
Right.
So
Yeah, this
you guys, this is a
calendar year, we've
whole
lost 7.
scary, yeah, this is a really, and
Yeah,
that's
I
why.
hadn't lost 17 in the 25 years before. Put together.
So Rick, is this something that can be?
Behavioral health usually is like, we're safe and easy and peace, love, and understanding, and no one's dying. It's not like the hospital where they're sort of like, it's part of their life. It's like, this is a sea change for us. And,
It's crazy.
Right, yeah, it goes back to the work that we did around the pain standards and being able to really root cause piece. Is this something that can go to the work group that's looking at how we spend the behavioral health investment?
Sure, I
And
just
then come
wanted to
back-
understand the boundaries and rules that we had to work with, and whether this was
Well, it sounds like they're
something
fungible
worth
in some regard.
pursuing, or I needed to pursue a different
Yeah.
path.
And I want to acknowledge, Jefferson County has my billboard here. I don't know if you guys have noticed it or not, but they have fentanyl as the leading cause of death from 18 to 45. I drove out of Deer Ridge one day, and there is my billboard that I'd asked to be put up in Deschutes County. Oh my gosh, so we're now getting 4, I believe.
We got lost and put up here in Jefferson? Wow, nice one.
I go, Kelly, and I go, Kelly, how did you get that billboard? Dr. Baker, it was his idea. It is because so many people are just out there, and if it's your son who's died of fentanyl overdose as a 17-year-old, it's gonna really break your heart. But so many people don't seem to realize how traumatic this problem is, and it's only getting worse.
Yep.
The fentanyl is just, and then it's laced with, horse
So that-
tranquilizers
yeah, I mean,
and.
if you think you're in a rave and you're getting a Molly, no, you're not. A little Molly and a little fentanyl.
So, do you feel like you have enough to take back to the group?
Sure.
Okay. All right, well, good conversation. Thank you for bringing it forward. And this is, the in the moment opportunity for us to really lean in and try to affect change. So,
Can I say one
thank you.
thing?
Yeah, go right
I've
ahead.
listened to Rick twice now. Rick, I want to acknowledge the emotion
Yeah.
that you have around this.
Yeah.
We offer solutions, but what I really want to do is acknowledge how I see this impact you personally.
Yeah.
Yeah, so our process is every time there's a death, we have a Sentinel event debrief that I and our chief medical officer personally lead. And so when you do that 17 times in the last 9 months,
I just want to acknowledge the
Yeah.
emotion that I see in you around this, that I've noticed.
Yeah, so
Thank you. Yeah.
even when you're old and crusty like me.
No, hardly. Thank you. Okay, well, more to come on that. I think we make that top of the list. That's definitely achievable. Let's go to next part. We're gonna talk about, well, let me set the table a little bit. We recently went through the board survey, and so thank you everyone for participating in that. One of the things that we recognized through that, which we're going to have a brief overview of here in just a minute, was that we really needed to do a bit of grounding again as to how did we get to where we are? Why are we doing what it is that we do? What is the purpose that we have? What is our role that we have? Outside of all the great grants and all the wonderful things that we do, what is our core purpose? And from there, why did we choose to look the way that we do in order to be able to achieve the things that we hope to be achieving? And so first, we're going to start with a brief overview of sort of the history, and then get into the governance committee. There will be a brief update before we turn it to Paul to talk about and Carmen to talk about the board survey. And then we'll have a brief update on the retreat summary, but both of those items will go back to the governance committee. And they will be creating a list of recommendations for us, a work plan, if you will, to put into the next, however many months or whatnot, for us to be able to unpack some of these things that are coming up within the survey, and how we will be taking that great work that we did with the retreat and embedding that into our work into the next few months as well, before the end of our strategic plan. So I have partners in crime here on the history piece. And last month, Brad and I were warm and fuzzy, so between, I don't know who wants to be warm or fuzzy, but I think Rick and Dan and Megan, if Megan's still with us, she said that she might have to drop off. So, okay, so there'll be three of us to go through the slides and talk a little bit about the history. And so I think I'll have Dan be warm and maybe Rick's fuzzy. And first start, we'll go ahead and just the mission of why, what it is that we're hoping to do, which is improve the health care by bringing down costs and raising both quality and satisfaction. As you'll all remember, we started out on the triple aim. We wanted to be able to bend that cost curve. We wanted to be able to have an opportunity to have better care, better access, better outcomes, and really try to shift what we were talking about at that beginning of, we're talking a whole lot about it being healthcare, but really it's moving around the dollars of medical care. We weren't really talking as a nation in our own communities about what does it mean to lead with a health lens versus how do we make the medical care better? We want to have great medical care, but we also want to make sure that we're getting upstream to the preventive components that are necessary for us to really start with healthy lives. And a lot of that is baked into, of course, the social determinants of health as well, which is something that we're doing through investments with a lot of our grants. And so our value to the, so our charge, well, you can all read. So Dan, can I throw to you the charge with?
Absolutely,
Okay.
yeah. I mean, without just reading, because nobody needs me to do that. We had this idea that we went to the state based on a group that was already coming together around sort of the mission that Tammy outlined. And when CCO 1.0, which is sort of the original, moving from fully capitated health plans to CCO model came around, the state said, tell us about how you're gonna do governance. And they had some thoughts about board composition, either for the organizations that were CCOs, for the organizations that were CCOs. And we went and said, well, we have kind of a different idea. We'd like to leverage a model in Central Oregon and ultimately in the Gorge that is what we call just sort of true community governance, right? And the Health Council and the CCO then went and said, it was literally almost a back of a napkin thing, and now it's the slide that Kristen presented at the beginning where the dollars flow from the state to the CCO. We have a local partnership with the Health Council vis-a-vis, codified in that joint management agreement, and then really delineated those functions underneath that were more governance and community health improvement functions versus performed by the Health Council or led by the Health Council. And then the traditional kind of managed care, which ultimately that list really grew, right? Because through CCO 2.0 and now multiple waiver upgrades or changes, we've taken on more roles, certainly, very much moving into spaces that were not traditional health insurance roles. But we've always been clear about, where do we collaborate and what are those delineated roles between the governing entity and the CCO? So that's kind of my take on this. And I think, Rick, appreciate sort of the best CCO comment. I think the reason why is that, it became clear early on that there would two things for me. We would never say we're there. We're perfect, we've solved all the problems, we're 100% on quality and the lowest cost and the best access, but that we could be better if we could sit around tables in this room, which we call the boardroom, or any of the committee rooms, and say, when a problem or an opportunity gets presented from the CCO, the view is we're not sitting here to try to solve their problem, we're sitting here to try to solve our problem. Right? Whether it's improving a quality metric or an access or bringing the voice of the customer in. And that's how we've tried to approach it. And it's messy at times and it's imperfect perfect at times. And, you know, this problem, even Rick, that you brought up, one of the things that just sort of pains you is there's, I'll say this in a way that we can sort of roll our eyes or even laugh at, but where else do we have this problem? We have dollars sloshing around. We literally have dollars sloshing around. We're gonna have another year of large shared savings, and we struggle sometimes to even figure out how to get them out the door in a timely basis. And so I think it's a reflection of probably the good and the bad of the model, right? It's sometimes you can move at speed to be autocratic, right? And just say, this is what we're gonna go do and we're gonna go solve it. But we have problems like this that remain unsolved because we have to regulate it to death or work group to death. And that's not necessarily only our problem. I think we've done it better than most, but that's where there's still that room for improvement.
And it's still a little slower than some would like. So one of the things that you'll note is that we have a regional health assessment and a regional health improvement plan, and that's separate legislation that we have in our region. And this is really to honor the work that gets done through our counties in being able to reduce the number of planning a plan for the plan and submitting those to the state. And so it was a way for us to work as a region because there's a lot of synergy around Crook, Deschutes, and Jefferson. And so we are allowed to do that planning because of some of the special legislation that we have, which reduces some of the impact to your departments, whether that's maybe juvenile, public health, being able to use those planning efforts collectively. We get into the timeline, and Rick, I'm not sure where you want to jump in, but I know that seated around the table, so many of us have been, I know that Dr. Shercliffe was part of, Megan was in the room, Dan, Rick, although both not, trying to get dental to the table in the early days of the integration project was no easy task. Counties, we are at the table. You are all here for a very good reason, and that is because you're the boards of health as well as the mental health authority. This looks different through this timeline because we were the petri dish to try this out in the state of Oregon, and so.
I would add that there was a small group of us started to meet, and we met at Sageview conference room, which might suggest how crazy we were. And I'm not sure all the CEOs were aware of what we were doing. Robin Henderson was representing the hospital, Megan brought in really early, and the commissioners can blame Tammy and Mike Ahern for your membership on this committee, so you know where the fault lies. But we had an employee of the hospital who was an advisor to Governor Kitzhaber. And so we became the early test case. And it was a relatively cohesive healthcare environment that, and we all came together again as a community. And that's been something I think that certainly myself and Megan and many of us around the room have really appreciated, is that we've been able to move this forward in a more cohesive manner than has been possible in most communities. And I think that's sort of fraying these days, but I think that's something some of us old crusty folks really think is a huge advantage in this area, is if we can work collaboratively in problem solving.
And it was originally called Links for Health, if you'll recall,
Yeah,
after.
my wife still calls this whole thing the white paper.
So there was a white paper.
There was a white paper.
And Mr. Link was a client, someone who was part of the then system, who we were not able to affect all of the change that we would have hoped to have been able to affect in his lifetime. And so so it's I think that patient or that person rather centered piece of how do we do this better for our community has been a constant theme. So then we ran legislation alongside the state in case the state decided to do something that looked like a whole lot different than what we wanted to do. And so there are some variations, but we still operate under separate legislation that allows us to do some of these things. And then also we had an opportunity to make sure that we remained as a community governance model that also celebrated like having education at the table. How are we looking at this holistically as a community as well, and not just, again, looking at kind of the medical aspects of it. And so I'll let you read what is up there, but 2020, we launched the work groups, and then sort of brings us a bit more into present day. So the piece, you know, on the days where it feels like we're just not moving quite as fast enough, I think if we can look at where we had been, it may seem like a long time ago if we look at 2011, 2012. The formation throughout the state is actually a few years younger than we are. And the fact that we are able to continue to look at what does it mean for us to show up every month and actually drive this forward, and how do we get past those barriers and those bumps where it feels like it's either not fast enough or it's not aligned enough. None of this is easy and it's messy, as Dan mentioned earlier. But if we don't continue to give it a whirl, who will? You know, this really is what systems change looks like. And the thing that we started is trying to shift something that was decades. The only care that, system that we knew of was the one that was built previously. We're trying to redefine something entirely new. And so we wanted an opportunity to make sure that you know why we come together and why we exist the way that we do. And so we're to provide that oversight, strategic direction, transparency, and the collaboration. And that'll turn it to Dan and Rick if there's anything else you want to add. And that's sort of the level setting of the why. And Paul, having read all of the survey results, if there's anything that you feel like we've missed or left out, please.
I think what we, you know, the discussion, you know, who should be on this board, you know, was all the people who have deep, you know, who are operating the system. Plus, I really always thought that county commissioners were there because we needed representation from the citizens of the counties. And who represents the citizens of the 3 counties but the county commissioners? And so that was the key in my mind for those folks. And then we realized education was so intimately connected with what we were doing. You know, so we just started putting these pieces together, and then, you know, representatives from the CAC, so we had representation from members. So I have always said, as I've said many times before, I view this as sort of like an irrigation district. You know, it's the members who are running the thing.
Oral health got on there because they're integrating oral health, physical health, and behavioral health, but oral health was always, nobody ever mentions it. So I started coming to the meetings and started hollering a lot and saying that we were all at risk until the hospitals got at risk. That was my favorite thing to say, because all around the table, if they're not at risk. So the hospitals are at risk because, a lot of it partly because of me pounding on it and you folks doing it, but finally got advantage
What
down to
actually
the table.
happened is Mike was so good at advocacy that he got in the rooms with the governor and got dental put in there.
Actually, I sat on the committee that developed all the legislation.
Right.
I was the oral health representative that was in the gang of 6 that actually developed the legislation.
Yeah.
So I really know a lot about the legislation because I was in all the backroom meetings at Mahonia Hall.
Yeah.
Compromising and all the stuff that went on. And the very first thing that happened as seniors got out of the room, nobody wanted that advocacy group to come down. I mean, literally got the first meeting, the first minute, you're out. The seniors are out. That's why, because of the power of their politics, they got out. So yeah, you're right, Rick.
So here we are, and does that, I want to also call out that we have all but one member with us today.
Yes.
Of the Health Council Board, and that's, doesn't usually happen, so thank you everyone for making time too. Yeah, we did get a selfie with the commissioners, thank you all, yes. So we wanted to just level set. Paul, was there anything, I'll turn it over to you. Was there anything that you wanted to say?
Do you want me to move right into the results or
Sure, yeah, that'll work, and we can do a, okay, very good, yep.
Yep, so the only thing I would say as a segue from what you just shared is needing to revisit this every once in a while. I think one thing that I took away from the evaluation, the survey results, is we have at least one person, if not, we have people all the time who aren't always sure what our mission and vision is, aren't always sure. And so as we talk about onboarding, as we talk about revisiting what you just revisited, that's something we've got to do continuously as we have new board members. So that was in terms of a segue from there. Carmen, did you want to
I mean, I
set the
could,
stage?
sure, I can just give a high level of the board's self-evaluation summary and the results. So this happened back in June. July, we had no board meeting, and then August, we had a full packed agenda. September, so I apologize that this is a little bit delayed, but here are the results here at this moment. So what we had done originally was the board had approved 4 sections that need a quantitative review on duties and responsibilities, strategic plan, knowledge, fiduciary oversight, and engagement and conduct. So within each of those 4 areas, there were 3 quantitative questions that were asked. And just as a high level, 12 out of 14 board members responded. However, we actually got 13 responses because it's an anomaly and we can't trace it back because of the survey is anonymous. And so there was one participant that actually triggered it twice.
Love the survey so much,
yeah,
they
yeah.
filled it out twice.
And I think that really helped our members actually.
Yes.
So,
Nice.
With that said, it did sway, which is really nice on the quantitative findings, that 88% of the responses, most everyone agreed or strongly agreed where they were in these areas. 8% of responses were neutral and 4% were either disagree or strongly disagree. So I think there's an opportunity there to really understand, if you look at the detail, it's really one person that is saying strongly disagree or 4 different people in the different sections. So, I think that there's a way for us to say, okay, what does that mean that we're not all strongly agreeing, that we understand our duties and responsibilities, our strategic planning, fiduciary oversight, and engagement and conduct. So, some of the pieces there will actually speak to, it'll go back to governance committee, and then we'll lean in a little bit more on, is it our board orientation process? Do we need to do more education on a regular cadence? And so that's some of the findings that we were finding. Fiduciary oversight, a lot of that is really about understanding our whole JMA financial model. As you can see, even some of the questions that came up during the audit review, how far are we leaning into truly understanding those pieces? And then engagement and conduct, that's just participation. And also in our board policy manual, there's actually a section there that each board member would bring in community folks or other leaders in the community so that they can start engaging with us. So there's definitely opportunity in a lot of those spaces. The qualitative piece, that's qualitative, that's free form text. And I actually included it all the way in back here so you can see the specific comments. But in essence, it was basically summarizing about we need to start paying attention to some of the emerging issues. Emergent topics included substance use, obesity, which are already addressed in some of our current RIP work. Who did that come from? I don't know. But
I don't know, but we have 100 million Americans that are obese.
Okay.
100 million. But no,
Yeah.
I was in the market the other day and I thought there's so many aisles in that grocery store, you shouldn't even go down. What is in our food. And so much that's in our food today, it's not allowed in Europe.
Right.
Support ag.
Yeah, it's so true.
So anyway,
And then another topic that keeps rising up to the top is seniors were also mentioned, and it's really about prevention for the aging population. And so, you know, how do we lean into those topics as well? Let's see, what else? Comments were anonymous. Critical discussions came up on strategic plan clarity. And another thing that this brought up was that there are emerging topics in our community, just like the one that Rick, you know, we discussed. And then there are critical discussions that how does our board lean into those? And I think those are the type of topics that we'll be presenting at some point after discussion and governance. So those were the high-level findings. Details are attached here, and if you have any questions, let me know. What we want to do is, this is the first time that these numbers have been baselined, and so we'll probably ask the same questions next year for the quantitative portion, and then focus questions depending on what's emerging at the time.
Carmen, there's a new issue though that I wanted to share with this group. It's that 16-bed rule that came from the 1960s about secure residential facilities for people. Senator Wyden is actually meeting about getting rid of that rule. And so I am calling all of his numbers and saying, please, could you do that? Gina Nichols, who's the director for the Association of Oregon County Commissioners, is on his committee because she's a behavioral health specialist. And she goes, Patty, they're actually talking about getting rid of that rule. It would be so outstanding to be able to build, you know, like an 80-bed facility where mental health, you know, Oregon is what are we, last in the nation, second to last in the nation for mental health facilities. So, and he's working on it. So if you all could call his numbers and just let him know that we need to get that done sooner rather than later.
Now, the rule is from 1963. and
Yes.
Actually called the Institute of Mental Disease Act, so.
Oh, thank you, Rick. I mean, that rule's been bugging me, and then now that to get to the bottom of it, there's actually a chance that we could get rid of it from the 1963. What an optimistic thought.
Wow. Talk about government movement.
Let's not.
Wonderful. So thank you for that. So we'll have an opportunity to baseline ourselves and then look next year and see if we're moving the dial. If not, it gives us information. Thank you, everyone who filled out the survey, so we know, are you getting what you need? And is this sort of, are you feeling like you hold the information to be able to be an effective board member too? So thank you.
And I'm so proud of the person that did it twice.
Oh, right, exactly. Maybe they're
I hope
hoping.
it wasn't me.
Maybe they're hoping to change their.
I always hate to miss those
I
things.
just want to know whether they scored themselves the same.
Yeah, right, exactly.
Or was it different
Yeah.
both times?
Yes. Okay, so let's move on to board retreat. So, and again, this is a bit of a flyover. This will go back to governance. They'll have an opportunity to dissect it a little bit more, offer a bit of more context around a process to be able to add some of these ideas to a work plan, so we can start achieving some action here at the board too. Okay, sure, yeah, go right ahead.
Okay, so just to reflect back, the board retreat happened June 6th, I believe. And so I work closely also with our consultant that helped facilitate this. And instead of giving you 20-page of notes, this is what it's summarized to, is that we've identified, you know, really 5 themes that really came out of the board. And I'll speak to each one of them briefly, but they were leaders of influence. We spoke about that earlier. Critical discussions, measurements and outcomes, strategic plan clarity, and continuous improvement. So the leaders of influence really speaks to the power and influence of this board and the way that it was structured. And I think that the conversations around the table around the retreat really recognize that if we were very intentful and, you know, how do we move things across the health system? And I believe that that's the whole reason it was set up this way, and really start to work on those emerging issues or critical discussions that we need to have. So that was really uplifted. The staff also recognized that and also observed that, wow, we have a lot of amazing people on our board. Let's start moving the system. So that's the influence that this board has. The second piece are critical discussions. you know, throughout the retreat, there were sort of topics that came up. And they weren't necessarily emerging topics like the difficult medical or operational things that needed to happen in our system. They were critical discussions with regards to our board and our board dynamics, where how do we do our deep dive discussions, and you'll see that in the detail that I'll go through next. And then the third one is obvious. You know, we looked at our strategic plan and we're meeting our goals, but the question was, how do we know that we did it well? How do we know that our investments are, there's a return on investment on them, and that we're improving the cost of care? So that's a lot of measurements that aren't in place, but also it takes a lot to get it there. So a lot of times we set goals, but then we don't know how to measure them. And so I think that's an opportunity for our next strategic plan on how do we do that. Strategic plan clarity, really that was the theme of why we also got together during the board retreat. We have been into our strategic plan through the fourth year now. Next year will be our last year within our cycle, and then we'll create a new strategic plan. And we had not had the opportunity to really lean in and say, are we still on the right track? You know, can we get rid of some initiatives that are no longer in alignment? So that's a lot of what we did during that time. Was we have a lot more clarity now as far as where we're headed, hopefully, and you'll see the detail on that. And last but not least, continuous improvement. And this is whether it's operations or, you know, as COVID emerged, you know, there's really a lot of opportunity in like education, reviewing other system models that, you know, that are out there that people are bringing up. How do we bring those pieces and really transform where we're headed as a group? So that's a lot of, you know, the places where, how can we improve this? And, you know, like, if there are legislative requirements, we have to operate within that. That said, how do we come up with solutions around it so that we can still, we can't just say, oh, well, we can't do that. You know, it's like, well, we can do this though. And how do we partner to get that to go to happen? And then the last piece is just really accomplishments, just really recognizing that within the 4 years, within when the strategic plan was built in the middle of COVID, we still did move the system. Investments went out the door. We're starting to do more collaborations across the work groups, and, you know, to really recognize that even our regional health assessment, this is the first time that we have a community survey that's going out, and, you know, really leaning into a lot of the responses based on community and not just secondary data. So that's sort of really my high level review of that. And then the next pages, what we did was we put these themes and we mapped the strategic initiatives that reflected them. So if you look on page 61, for example, leaders of influence, review delegation of legislatively required seats. That was something that was an action item that we pulled after the board retreat. And that strategic initiative lines up under effective governance. And those strategic initiatives were the 6 initiatives as part of our strategic plan. And then the last column is it's in progress or we're about to do them, but I do believe our staff will need, you know, further direction as to which ones do we prioritize, or do we move some of these into our next strategic plan? Because not everything is going to be tied down. You know, like for example, this tribal engagement leadership with COHC leadership. We really need a lot of support around that, and addressing, that's part of the strategic initiative of addressing inequities, and it's still to be done. I mean, that takes a while to build those levels of relationships. Critical discussions, I think governance will have a lot in terms of how do we prioritize some of these action items. You know, we talked about additional revenue streams, committees and work groups, more inclusive and promoting leadership. So please look at this and take a look at which ones really call out to you, because we'll need that feedback as well. And then you can see the other themes also coming into play, measurements and objectives. We could create key performance indicators in the next RIP planning process. That was something that we talked about But how do we do that if we don't have an infrastructure to measure it? And so that's, on one piece there. Strategic plan clarity, for example, we're officially sunsetting the CUSC committee. And that's completed, but maybe that will evolve into something else. So these are the pieces that came out of the board retreat on a high-level summary. So let us know if there's something we've missed or we need to restate.
So like I mentioned, this will go back to the governance committee.
Yes.
And as governance chair, do you want to, so both of these will go back and then we'll have an opportunity to sort of put it into a work plan that Carmen is working on as well, so we can prep our board meetings a little bit more strategically about the things that have come up in both of those documents.
And the proposed plan
Yes.
of how we address the issues that we've talked about today. Specifically, what the differences between a critical emerging issue, I would call it, versus a deep dive issue that may be uncomfortable, but is not as critical as the fentanyl crisis, for example. So we'll come back with some recommendations on what topics we'll include in that on a quarterly basis. In fact, I sent out an email to the group, to the board a couple of weeks ago and asked for your thoughts, and I know a number of you have responded. Our next governance committee meeting is on Monday, so just a reminder, if you haven't responded on what are those deep dive topics that we've sort of been avoiding, not consciously or intentionally, but things we really need to get in and talk about even if they're not comfortable. So governance committee can have a complete list and do some sense of prioritization and scheduling which ones come first and bring those back to the board next month. We'll do the same thing with the board survey that Paul and Carmen just presented on to see what additional recommendations beyond today's presentation on how we were born and to, with the benefit of a new member, be able to reorient the entire board. We've had a lot of board change, and I can't say that our board orientation has been impeccable up to this point.
And got some improvement.
Some people got some things, some others. So we're thinking over this next year, if on a monthly basis, we have a board orientation topic, reminding those of us who either didn't get it or are older and don't remember it, be a chance just to refresh and define for ourselves what's our role, what are the lanes we play in, that sort of thing. And so the governance committee will come back with that list. And then the third thing we're facing this month, or we'll be dealing with on Monday, is that also sent out an email about this a couple weeks ago. It's time for election of annual officers, chair and vice chair. And
I thought it was for life.
sometimes I like this that way, doesn't it?
Wasn't that the agreement? Yeah.
It's in our bylaws.
So.
Yeah, it's in the bylaws.
Lifers, we're all lifers,
President
yes.
for life, vice
Yeah.
president for life.
So if you have not yet submitted your nominees for those two positions, you have until end of day tomorrow to do so. Governance committee, serving as the nominating committee, will come back with a slate of officers for election either in November or December, depending on whether the people that are nominated are all in agreement that they're willing to serve. So that if everyone who submits a nomination submits it with the approval of the person they're nominating, that piece, we could do an agenda on Monday and get back to you. But if we have to take extra time to do all of that vetting, then it'll be December. But we will have an election no later than December.
I received two or three responses, and so if you want to send your nominations for chair and vice chair to me, then we compile them.
Great.
Can you send them twice?
I'll know who sent it.
Now we know who it was. Okay, Linda, anything else that you want to share from governance?
No, I think that's it. We've got a lot on our plate this next
Okay.
couple of months.
Okay.
And then maybe by the holidays, we'll go to Tahiti for.
Excellent,
rest.
Tahiti. Perfect, okay. We do have a short executive committee meeting, and so if we could maybe, just take a quick break and help break down some things, does that help?
Yeah.
Okay,